I am now particularly thrilled to introduce Janice D'souza, the moderator of today's conversation. And a note to Janice and actually to all of our speakers. These are people working at the intersection of racial equity, interfaith leadership, health and healthcare, health in communities. And we know that now and this last year and all of your working lives, but especially now has been just a profound time of the need for your work. So we're really grateful that in the midst of it all, you have taken an hour out for this conversation. You will see Janice and all of the speakers' bio in the chat box shortly, but let me just introduce Janice before I hand things over to her. Janice D'souza is a policy and qualitative researcher with a focus on sexual reproductive health and religion. She is an evaluation coordinator with the New York City Department of Health. Her prior experience includes conducting policy reviews at the CDC, training abortion referrers in Kentucky and across Appalachia, as well as conducting field research for Mahindra CSR's Girls Education Project. Janice has a Master of Public Health from Emory University and a BA from Berea College. Janice, we are so proud, is an alumna of IFYC. I'll turn things over to you.
Thank you so much, Becca. Well, we have a great group of panelists here. I would like them to introduce themselves. Camila, do you want to go first? Ooh, I think you, okay.
Sure.
Yeah.
Good afternoon. My name is Camila Pickett. I am a public health practitioner, a lawyer, an artist, a writer, an abolitionist, and a racial equity trainer. My work focuses on the intersections of race, justice, and health, and is most pointedly concerned with getting folks free. So I do work with incarcerated Muslims to provide bail relief, but I also make sure that I help organizations craft policy that is focused not only on folks' physical and mental well-being, but also their social well-being.
Oh, this is so exciting. Okay, let's go, Kimberly.
Good afternoon, everyone. My name is Dr. Kimberly Arnold, and I'm a postdoctoral fellow at the Penn Center for Mental Health in the Department of Psychiatry at the University of Pennsylvania Perelman School of Medicine in Philadelphia. I'm also a board member of the Black Church Food Security Network, which seeks to dismantle racism in the food system through the creation of a Black-led food system anchored by Black churches in partnership with Black farmers. So my work focuses on the intersections of race, religion, health equity, and social justice.
Right, Shani.
Hi, everyone. My name is Janice Jacobs. I am a third-year PhD student at Boston University School of Theology, focusing on constructive theology and ethics. My research specifically looks at how Black birthing communities use religious practices to make sense of the injustices in the healthcare system. And I am most specifically engaged in holding churches accountable to actually being on the ground in grassroots ways to be activists for Black birthing communities.
Thank you, everyone. This is such a great group of people, and I'm really excited to learn from you all. One of the questions that kept coming up when I saw the title was, how can interfaith leadership foster greater equity for the health of communities of color? And for me, interfaith leadership is building across deep difference, looking for points of connection and commonality. So when we think about that, what comes up for you? And we can start with whoever is open to sharing.
I'll go first. So when we were talking about the topic, my initial reaction was, I'm not an interfaith leader. I don't have a particular position in the clergy, and I don't minister to a population in any sort of way. But I am often in spaces where I'm the sole representative of people who sit at my particular intersection of being Black and Muslim. And so if we're asking if interfaith leadership can foster greater equity. I would say insofar as you assume that most folks are connected to a faith community, yes. But if faith leaders are looking beyond the confines of their particular community, absolutely yes. So I am Muslim, and my faith practice is one of liberation theology. So while being Muslim is an individual decision, and it is an individual relationship that I have with my creator, being a Muslim means that I am part of a community. And so I believe that my actions are weighed as an individual with how I comport myself and how I do things that my faith asks of me. But some of those things are my actions towards others, right? So it doesn't stop at sort of individual deeds.
Yeah.
I am responsible to a community of folks, and not just folks who worship as I do, but anybody that's around me, right? And so there's kind of a saying that, if you can't be well, if your neighbor is unwell. And so there's no indication of who that neighbor might be. They don't have to look the same, they don't have to pray the same, but just their proximity to me means that I have some level of responsibility over them, right? And so I think of it in those terms. What I may want for my particular community, what well and healthy and happy and whole looks like for me may be different from other folks, right? But at a very base level, we're all here together. And so we have a responsibility to each other to make sure that the things that we do bode well for the least of us. That if the very least of us is good, we're probably all good, right? And so I think that takes some cross communication. That takes people actually talking to each other outside of their differences and making those connections where they can to make sure that everybody is good, right? So that even if people aren't connected to a particular faith community, or if they are, but they're unchurched or unmosqued, right? That they don't get left out. And that is something that I don't think we talk about enough. And I'm saying we, like, I just told you I was not part and the interfaith leader, and now I'm saying we, like putting myself smack in the middle of the conversation. But I don't think that interfaith spaces talk about that enough, about people who are not connected to a particular congregation and the work that needs to be done in order to make sure that those folks are well, right? So yeah, I think probably yes and no.
Ooh, this is exciting. Thank you so much, Camila. Kimberly, what are your thoughts?
I actually have like a lot of similar thoughts as Camila, and because at first I was just like, I predominantly work with Christian churches, but as I was thinking more about my experiences, not only as a researcher, but just in my personal life, I thought of other types of spiritual systems that we sometimes don't think about or talk about that are outside of the predominant denominations and religions that people are more familiar with. And so in my case, I went through a rites of passage program when I was doing my PhD, and that gave me the opportunity to gain more exposure to traditional African spiritual systems and how there are a lot of assets that exist within these traditional systems that are connected to my ancestors, a lot of practices that we did and a lot of rituals that we did during that process are relevant to things that we do even outside of the context of religion. So even when it comes to health, for instance, going into the rites of passage, I didn't think that, health was really going to be a major component, but it was. And it was like throughout the entire experience, the focus was not only on spirituality, but on health as well. And so, and it really just brought me to a place of really thinking more about what holistic healing is, and then also the ways in which we can exchange this knowledge and information across different faiths. because at the end of the day, we have similar goals. And even when Camila mentions having that liberation theology perspective, that's the same exact perspective that we also have within the church that I attend, the Pleasant Hope Baptist Church, where we practice and study Black liberation theology as well as Black Christian nationalism. And so we really have that focus not only on social justice and spirituality, but also the health and well-being of not only our members, but community members as well. And so I think that another thing that's important to point out is that places of worship are located in almost every community that you can think of. And I have had the opportunity to live in different places. I'm originally from South Carolina, a very rural town. I grew up on a small farm, but there was a church located in my community. When I moved to Philadelphia for the first time to pursue my master's in public health, I actually started working with Black churches across the city and implemented different interventions that were focused on diabetes prevention, obesity prevention, and other chronic diseases. And I just noticed that in these various places of worship, regardless of what denomination it was, there is a church in almost every neighborhood. And then once I returned back to South Carolina to work at the Prevention Research Center at the University of South Carolina, I was working with a program called Faith, Activity, and Nutrition. And again, like I had the opportunity to kind of travel to some parts of the state that I had never been to before. And so I noticed that even in places where there wasn't a grocery store, there was a church. And so the presence of God just being in different communities that sometimes think that maybe they don't have a lot of resources, there are a lot of resources. And I really think that by us taking a more asset-based approach and really thinking about across different faiths, we all have assets. We have not only people who have different talents and skills within our places of worship, we also have space, we have money, we have land in many cases. And so there are lots of assets that we can leverage, especially assets as it relates to improving health. So we can leverage those assets across different faiths and really come together and think about those commonalities that we have, and especially in addressing common issues such as health disparities or social injustices. And we have the people, the skills, as well as the resources to really address these issues.
That's really interesting. I like thinking of interfaith leadership as also physical assets and resources. And I feel that's missing from the conversation sometimes too. Shanice, let's see what you have to say.
Yeah, thank you. Thank you, Janice. I am very much agreeing with Camila as well, and also Kimberly too, that I first would never consider myself an interfaith person. I feel like I have all of these different interests, and then people put a title on me and I'm like, oh, okay, that works, sure. I am doing this work. That makes sense that the answer could be yes. So to answer the question that whether or not interfaith leadership can foster greater equity for health of communities of color, absolutely. I think that one of the fascinating things I've seen in my work, whether it is in healthcare settings or within communities, is that people come together because they are desiring to achieve justice, especially around health equity. They are concerned with making sure that people get proper care. They're concerned with making sure public health infrastructure is in place so that communities can thrive. And then it just so happens that they also bring their religious identities to those conversations. But when we're engaging in these conversations, religion isn't the first thing that happens to come up. It's like, oh, well, I am a doula, or I'm a PhD student, or I'm a health advocate, or I'm a public health official. And I also attend this place of worship, or I also believe these things. And that theological framework informs the way I go about justice, and the way I go about justice happens to be sitting in this space with you all so that we can collaboratively think about ways to bring our communities into the room, because they have been left out so many times. And I think if we want to look at the ways that religion is also in that room, we will see that interfaith leadership is happening, but our faith informs the ways we go about justice. And I think that's no different from me getting to sit in these rooms with people, to listen to the work that they're doing, and to see the ways that they represent their communities who are often excluded from the conversations, means that a liberation theological perspective is being used to see how we can achieve equity.
Wow, that's so interesting. Something else I thought of when I was looking at the title is restorative healing. And I know a lot of our participants had a lot of thoughts about it too. I would love to know, what is restorative healing for you all? And where do you see that kind of healing in your work right now? Let's go with the roster and Camila start.
Yeah, I'll start. I just want to say one quick thing to follow up on Shanice's point. I actually do wear my faith quite in your face. You know that I'm Muslim when you look at me because of how I choose to dress. And so I don't have the option of not bringing it into spaces with me. Even if I am not there to do that, other people will often try and do that for me. They usually get it wrong, but they try anyway. And so part of me being in spaces sometimes is pushing back on notions that people have about what they expect of me, or what they expect of people that they assume sit in my space. So there's that. And I am thankful for all of the participants for answering the question of what restorative healing might look like for them. And I will admit that to me, it's one of those kind of crunchy terms that people use. I think the people who are practitioners of it have a really well-rounded idea of what it is, and other people not so much. And so I think of it in terms of restorative justice and transformative justice. And to me, those are about communication, right? And so restorative healing is kind of about a dialogue, because you're looking at a whole systems sort of healing, right? And so you can't bring any sort of effective change without having a strategy for resolving conflict, repairing harm, or building relationships. And it is grounded in a sort of mindfulness approach that is non-judgmental and is seeking to humanize both folks who have been harmed and people who might have inflicted harm. And when you think about that, that's clearly not the approach that our carceral system in the United States or anywhere else uses, right? It's not the basis of it. But in terms of healthcare and health equity, it's about the dialogue and figuring out where harm has occurred. But for me, also realizing that everybody has the everybody can harm and be harmed, and those things are not necessarily separate, right? You can inflict harm and be harmed all at the same time, and you can carry both of those things. And so in order for us to really get at the heart of how our healthcare system is set up, and make sure that it is transforming the way that it approaches illness, requires conversation, honest conversation. And it has to happen between folks who have been harmed and people who inflict that harm. And those are not conversations that we are used to having in this country in any context. Because if that were the case, then we wouldn't be having this conversation, right? So it really comes down to like an individual level of practitioners and what they are going to do with the people that come to them for healing, right? What type of conversations you're going to have to make sure that you are getting to the root of why somebody is ill. What things are you going to recommend so that you're not taking them out of the context of their family or their community when you talk about how to restore anything that has been taken away from them, right? So that's the context that I use when thinking about this.
That's good. I guess for now, let's just like talk about what does even restorative healing mean for us. I'd be.
I can hop in.
Oh yeah, let's go.
Okay. So I agree with Camila. Like, depending on who's using the term, it could be very empty or it could be full of depth. And I approach this conversation as a bioethicist. I feel like I'm public health adjacent in that I'm a public health advocate, but trained very much in bioethics. And so thinking about these conversations of harm and beneficence, there are 4 principles of bioethics: justice, autonomy, non-maleficence, and beneficence, because we're trying to do the most good, the least amount of harm, but center patient needs. And so when I come into the conversation, I am often focused on any sort of patient-centered approach. And when I'm thinking about the communities in which I'm engaging, whether that is Black birthing communities or Asian communities, to figure out how we can all come together to reduce anti-Asian violence, their voices need to be heard. And oftentimes when we're within healthcare systems, patient voices are excluded completely because there's this parentalist approach that says, Western healthcare knows what's best for you, so we're going to kind of do it to you diagnostically. There are no preventative measures. There's no aspect of holistic healing. And I'm being overly simplistic here because these spaces do exist, but more often than not, people do not feel as though this is the care that they're giving. So when we think about restorative healing, I second very much dialogue. What does it mean to have a patient-centered approach? What does it mean to have a person-centered approach, which then expands to a community-centered approach where the needs of these people in these communities are actually at the fore. We're understanding what the real issues are. We're understanding what resources are actually needed, and we're understanding how to implement those sources in a way where the communities actually feel as though their needs are being met. And myself as a researcher or a student or whatever, I'm not just coming in, asking a question and then using someone as a case study, as has often happened within the history of US healthcare, to say, great, got what I needed, and you probably won't be able to have access to these resources for like another 50 years. So I very much agree that patient and community voice has to be centered in order for any sort of restoration to be made.
I agree with what has been said so far, and I think that that is one of the issues that I've just noticed along the years of just, you know, working in the field of public health. And you know, there are so many people that want to do the quote unquote right thing. They want to do well, they want to do good, but the way that they go about doing it is not an asset-based way. It's not in a way that honors cultural traditions and practices. And sometimes it's just straight up like a paternalistic approach and just saying that I have the answers as to your problems, and I have the answers for how you should heal, but we really need to flip that paradigm. And I know that in many cases, like approaches such as community-based participatory research are used or promoted, but it shouldn't be that the community is participating. The community should be leading these efforts and really be seen as equal partners in addressing issues that they have identified as problems, and not necessarily researchers or scientists or policymakers or whoever else coming in and saying, I know what your problem is and I have the answer to fix it. And so we really have to take that approach of really like taking that step back and really focusing on relationship building, which does not happen a lot in the space of healthcare or within the space of public health. And so it's really important for us, if we are going to move to a place of restorative healing, that we really have to take that approach of really focusing in on relationships and really listening, and not just doing it as a checkbox and saying, okay, we had a couple community conversations and we're still going to proceed with doing what we want to do. And so for me, restorative healing really is about taking that trauma-informed and a holistic approach at multiple levels to really address the harms that have been done, and to also just take that approach of understanding that health is not in a vacuum, and that there are so many different factors that influence health. And so if we are going to heal, we have to think about all of those different elements and factors that contribute to health disparities and adverse health outcomes that are disproportionately experienced by people of color. And so another thing that I just wanted to mention, like in terms of the work that I do with my, not only with the Black Church Food Security Network, but as well as within my research, of just really having that multi-level approach, because we can't also just only focus on the individual, because the individual, again, is not in a vacuum, and we live inside of families, we live in communities, and we have multiple communities that we are part of. And so really acknowledging that intersection of those various identities and communities in which we live and in which we operate in, and then also in thinking about even other levels outside of the individual, the community, but also at that policy level as well, because policies created a lot of these issues. And so there are ways that we can now, undo some of those policies and pass new policies that are more equitable and that promote justice, not only for various races that have been done wrong before, but then also different socioeconomic statuses, like various religions, etc. And so one of the things that, especially when it comes to different faith communities, as it relates to restorative healing, from my perspective of being a Black woman, a Black Christian woman, some of the things that we do is like we provide health education in collaboration with various community members, addressing social determinants of health. So when it comes to food, for instance, everyone has to eat. And so that's why one of our main goals for the Black Church Food Security Network is to connect Black churches with Black farmers and to really build upon those assets that we have within our own community to address food insecurity and food apartheid. And then when it comes to even delivering health prevention and promotion programs, these programs should be chosen and selected by community members who are experiencing these conditions. And that was one of the things that I used to go through a lot when I was, starting out in my career. I didn't really know a whole lot about the ways that we should go about, delivering interventions. And again, it shouldn't be like I'm coming to you saying I have this intervention that is going to be beneficial. It should first start out with that relationship building and seeing that you might already be doing something to address these issues. And many times that is the case, in which communities are already doing something to address problems that they have identified. And so sometimes when outsiders are coming in, it makes it seem as though, oh, the communities aren't doing anything. And that's not the case at all. So it really does take that relationship building step, as well as working together to figure out what are the assets and then what are the gaps and how can we work together to fill in those gaps.
Since we're starting the conversation of what restorative healing looks like in your work, Kimberly, Camila and Shanice, how do you see that playing out in what you do?
I think I want to take a step or two back and say something that I would not be me if I didn't say. So I have been on I have been on both sides of health policy. I've been a person who has helped to write it. I have been a person to help to implement it. And obviously I have been a person who has borne the effects of policy written way before I was born. What I notice is that a lot of policy directed towards Black communities, other communities of color, policymakers tend to focus on the thing that worked, right? Like the big thing that worked. And so 60 years ago, it was the Black church for Black folks. That was the hub of the community. That's where all programs funneled through, right? At some point or another, whether it was a food program, vaccines, any public health intervention that you can think of that's been targeted to Black people has run through Black churches. And what I will say is it's 2021. And that model no longer works, because Black people are not just Christian, they are Muslim, they are Jewish, they are all manner of faith and no faith, right? And so if your model of addressing health inequities centers on running through one model, you're going to fail, because you're not going to reach everybody. And while I take Kimberly's point that, you know, a church in every community may be a sign of people's relationship with God and a good thing. I'm not saying it's a bad thing. If there are churches in communities and there are no grocery stores, that's not good, right? Like that's not a good thing. That means that at some point, people had to decide between the building fund and food, and they chose the building fund, right? Or that means that at some point, things that were supposed to be funneled directly to people didn't get there. And those are reasons why people pull back from institutions. And it happens in masjids too, right? Where people go for help, they don't get the help that they need, or they don't get enough of it, and they look at it not as a public health intervention failing, but as a failing of the religious institution in and of itself, right? And so then they separate themselves from it. And, you know, it's hard to convince people that, you know, what you're doing is research-based, that it may, you know, close racial equity gaps, that it might be good for them, just as like, you know, Camila and Janice said, right? Like it's hard to convince people of stuff if you have not made those bonds with them, but it's even harder to convince them if you've done it once and failed, right? It's harder to come back the second time and say, oh no, this thing is definitely gonna be the one that works, right? And so people just end up siloing their issues and their concerns, where they go to church or they go to masjid to go to be that in that place for their spiritual well-being, right? And they look somewhere else for everything else, right? And that's fine if that's what people want to do, but that's not liberation theology, right? That's not making sure that you are taking care of your whole community. And that's not where equity conversations are going to happen, or where racial equity gaps are going to be closed. And so it takes a rethinking of how we have conversations, right? That means that faith communities have to have really hard conversations about how they operate, and take really hard looks at their internal processes and who they're reaching. I'm in Atlanta. This is the home of the big church, right? This is what we do. We do big churches, we do big masjids, right? We do big spaces that are really beautiful architecturally, and they have amenities that people love, but folks are still hungry, right? Like folks still don't have healthcare, and it still takes these institutions a while to reach as many people as they could. And it's not indicative of everybody, but it just wouldn't be me if I didn't point out that that happens more often than we like to admit, right? And that is a hurdle to true equity, right? Because you have to start, if you're gonna have restorative healing, you have to have these internal conversations. And I don't think that a lot of communities are set up to do that, right? You're not set up to challenge folks that you've imbued with some sort of safeguarding of your spiritual well-being, right? We're not socialized to do that necessarily. And so it takes those really hard conversations about how our faith institutions are just structured, and what they feel their responsibility is and how they best do that. Because like Kimberly said, right, like it can't be them even deciding what interventions are best. It can't be a religious institution taking funds from the government to do outreach, if that's what the folks in that community have not decided they're necessarily cool with, right? Like it can't be them taking CVE money and then saying we're helping the Muslim community. No, you're not. You're being a part of surveillance and the carceral state, but you're definitely not helping folks eat, right? Like, how do you balance those things? And until we have those conversations, then we're always going to fall short of the type of healing and the type of equity that we actually really need from our systems.
I definitely agree with what you said, and I want to be clear that when I mentioned, that there are in certain communities where there isn't a grocery store, there's a church. I was mentioning that as an opportunity, that there are assets that exist within that church that could be used to then create a grocery store. Or in the case of the work that we do with the Black Church Food Security Network, in addition to making those connections between Black churches and Black farmers, we also have two other programs. One of them is Operation Higher Ground, in which we work with Black churches who are interested in creating community gardens, or if they already have a community garden, helping them to scale it up so that they can grow more produce, learn more about different ways to grow different types of produce, and then also storing it afterwards. And then we also have the Black Church Supported Agriculture Program, where we have where we basically provide the opportunity for different churches as well as individuals to actually order directly from Black farmers that are within the network, so that we're distributing and circulating that Black dollar, as well as providing food at an affordable rate. And then we also, of course, give away food as well. But it really comes back to that self-sufficiency and not just having a charity model, because that's not what we believe in. And that's what has failed us, of just having people giving handouts or saying, oh, I'm going to come in as a nonprofit organization and just, determine what your needs are and just give it to you. So we really focus on skill building and capacity building, so that it's not a situation where we're just like another food justice organization that's giving away food. So we not only, again, providing those skills on how to garden, not only for churches, but individuals as well, of having webinars, especially during the pandemic. We've done a lot of virtual meetings, workshops, and webinars on teaching people how to garden, even at home. So it really comes back to really focusing on what are some of the things that didn't work in the past when it came to the Black church, and what are some of the ways that we can change that moving forward, so that we are more focused on self-sufficiency and not even having to depend on existing systems, who have failed us time and time again. And also, I meant to mention this earlier, but when it comes to this conversation around race and restorative healing and all of this, we cannot have these conversations without acknowledging the role that racism and white supremacy has played in creating these inequities. And so, as we have discussed already, that there have been a lot of failures from the healthcare system, from the public health system, for the healthcare system having that attitude of, or that model of, let me just do something to you because I'm the expert and I have the answers. And then, experimenting on us, excluding us from access to care, access to high quality care. But then also on the other side, within the system of public health, there have also been those injustices when it comes to doing research studies that were unethical, and also having those situations in which, again, they were taking the model of, I have an intervention that I think works based off of evidence that we weren't even a part of creating, and then coming into communities and saying, I have the answers to the problems. But as we can see in most situations when these research studies occur, it's like, okay, I go in, collect the data, and then I'm gone. And there's no focus on sustainability. There's no focus on skill building. There's no focus on self-sufficiency. And those are some of the reasons why these interventions and programs have failed, and we have not moved the needle when it comes to health disparities, because there has been a lack of cross-sector collaboration, a lack of interfaith collaboration, a lack of collaboration in general. And there have been some examples, and there are examples of successful collaborations to address disparities, but it just hasn't been widespread enough for us to actually see meaningful change and meaningful outcomes as it relates to health disparities and actually trying to achieve health equity.
That's really good. I think for me too, when I saw restorative healing, I was like, what needs to happen even before restorative healing? Like, the conversation has to open up. And how do we acknowledge all the damage that's been done? Shanice, I'd be really interested to hear your thoughts.
I don't know if there's much more I can add. I think that Camila and Kimberly both had very important points that are really central to any model of restorative healing, especially for communities of color. The only thing I can do is speak from my own work. And one of the things that I often see and that I'm often encouraged by is the collaboration that comes just, I guess, first and foremost from kind of being participants in communities of color, because I have seen it like that step back where I'm doing this only within my religious organization. So I'm Baptist. So the Baptist church may have one seminar a year on what restorative healing may look like and how it hopefully can be achieved with like the kingdom of God coming or something like that. But to actually, kind of like Camila was saying, understand that the conversations I needed weren't happening within the church. So I went elsewhere. So I'm in these grassroots organizations where people understand that across communities of color, there are concerns and that we need to have conversations with why we need to come to this space to have this conversation, because our religious institutions haven't provided the space and cultivated the skills that we needed. So we are here now as representatives, and as representatives, we are approaching we're approaching and addressing those frontline issues. And I think that there's so many beautiful relationships, because then people get to take what they've learned and how they want to implement it into the workforce. And then they get to be representatives there as well. The biggest issue that I have with that is it's all the burden on communities of color to still do this work, to still champion and fight, to say, I'm a representative with this grassroots organization, or I'm a representative for my religious institution, or I'm a representative within the workspace. And back to the point of white supremacist structures and historical disadvantages that have been placed on these communities, I still have to fight as a representative in this space. So the entire framework of restorative healing just becomes oftentimes, like we mentioned, this empty phrase to say, yeah, we did it. You know, this is anti-racist. We kind of got equity. We have a representative here who leads the workshop once every 3 months. So it's kind of done. And I don't know what it looks like to get larger communities on board to actually do the work. I think for a minute we were there after the death of George Floyd with Breonna Taylor and Ahmaud Arbery, because that was one of the first moments the country woke up to say, wow, this has been really bad all along. And communities of color were saying, we've been living this all along. Thank you for finally seeing it. And I think now the responsibility isn't on communities of color. We are still representatives to bring ourselves and our communities into these spaces, but the responsibility is on others to actually do the work that they have the resources to do as well. So I am agreeing with both, sitting in this intersection.
We have about like 10 minutes, and usually at this part of the webinar, people start talking about like next steps. How do we move on? And usually I'm always hesitant in these conversations because I'm like, but we just started talking. Like, you know, we just started figuring out what is needed and how do we go to next steps. But I'd be interested to know your thoughts on next steps, on what needs to happen, who the burden of restorative healing falls on, anything, any thoughts that you have.
There's a question that I wanted to answer in the Q&A. Paul Habersock, I think. But he asked, where does healthcare go to help people of color get beyond being seen as objectified recipients, i.e. involved rather than objectified? I would posit this. Everybody is objectified and a recipient in the US healthcare system. That's just how it was set up. Some people clearly get the shorter end of the stick, but it was set up to objectify us all. We are all customers, payers, dollar signs. That's how it works, right? A better model, and one that would include all of the things that we've talked about and some semblance of restorative healing, would be one where folks could get the care that they need without regard or respect to insurance or copays, where they will have access to healthcare in their neighborhoods that is culturally competent, and not by a definition of culturally competent that just said, that just says Black people like these things, Asian people like these things, right? Because I've been on the end of Muslim women like this type of healthcare, and it has nothing to do with any experience I have had my entire Muslim woman life, right? So we have to fundamentally change the way we think about healthcare in this country so that it is not a product or a commodity to be had or negotiated with, but it is a right, right? Because we have the money to do that. We have the people to do that. It just has not been done because people who control it don't think it makes fiscal sense, right? Somehow it makes more sense to have people sick than it does to have everybody well, right? So it is having conversations that change the way we talk about healthcare and what it is and what it looks like, where it can be located, who can administer it, who can be involved, right? I have done work with all ends of the age spectrum, from Medicare recipients to kids in public schools to parents trying to get their kids healthcare. And in every situation, one of the biggest impediments outside of cost and access was people not knowing how to have conversations about their health, right? People who knew how to advocate for themselves in every other arena of life, they would get in front of a healthcare provider and just freeze up, not know what to say, and just kind of take whatever that person gave them and then either leave with something that didn't fit or something they couldn't afford or something that wasn't practical for their life or wasn't what they went to the doctor for in the first place, right? And as public health practitioners, we know that. We have study after study after study that says, you know, that Black women are not listened to when they go to the doctor, right? We are the last folks that they want to give pain medication to. We have the highest amount of maternal mortality across all social economic statuses, right? Across education, across income. We have the lowest outcomes, right? And it's not because of anything intrinsically wrong with us. It's because of the way that the system operates and the way that folks talk about healthcare and who is a dependent, who is a drag on the system, and you know who deserves more. And we can even see that most pointedly in the vaccine distribution, right? Vaccines should be going to communities that are most densely packed and that have less of an ability to socially distance or to stay home from work or to, you know, have their kids be home. Those are the people that should be getting it first. In every single major metropolitan area, those are not the people that are getting it first, right? It is not supposed to be dictated by income, but it very much is. It is supposed to be going to people who need it first, and that, according to, you know, the mortality rate, would be Black folks and brown folks. We are not the people getting it first, right? And so I think that we tend to separate out conversations, and when you do that, you lose sight of the bigger picture. And the bigger picture is the system doesn't work. And one-off attempts at equity may close a particular gap, but not the whole thing, right? It may make a momentary increase, but there are ways for you to close gaps or close gaps for one population and increase them for another one, right? And it shouldn't be the seesaw thing. It's not a zero-sum game where if one community gets access and that means that another community doesn't. That's how we've been socialized to think about it, but that's not how it actually is. And so I think if we broaden the way that we think about health, broaden the way that we even think about equity, right? And what that means, that it's not something that white people are giving to Black and brown folks, right? It is something that they need to do for their health as well. Because your physical health might be all right, but we are talking about faith, and your soul can't be right, right, if you're doing that. And so I think if we broaden those conversations, then we'll get closer to solutions that actually work.
I would love to hop in on it. Thank you, Camila, because that's also the question I was going to address as well, which I think ties into Andrew's question also. Absolutely, semantics are huge in determining who gets access to healthcare, what health actually is, and how health is deployed. And we absolutely have to change conversations around what health means and how it can be holistic. It is not diagnostic at a base level. Also, we can't just think about healthcare as its own system. Healthcare, like everything else, is influenced by all of the systems around us that exist socially. So to just think of addressing health on its own without fixing the other parts of society gets us nowhere, because you're still in the same place. There is a phenomenal scholar at Howard, Dr. Gay Byron, who does a lot of work on centering and decentering. He very much taking this point, just because one community is decentered doesn't mean the spotlight just goes on one other community. It means everybody gets a seat at the proverbial table. And because everybody gets a seat at the proverbial table versus people having to stand like in a line outside the door, means that the conversation gets to be more robust to actually understand what all communities need, so that their needs can be at the table, and so that we can discuss how to fairly and justly allocate resources so that all communities' needs can be met. Back to that idea of the least of these. And if we're thinking about a single payer system, there's tons of research that talks about the benefits of a single payer system and how it can just change US healthcare wholeheartedly. That is not what our capitalist model likes to hear, so we don't do it. But even with that single payer system, again, if we don't fix the systemic issues at the core of our society, if we don't talk about how one group is privileged far above all other groups, then that becomes problematic, because health, like Kimberly was saying, is not in a vacuum. We can't think about individual nor communal health in a vacuum. We can't think about the healthcare system in a vacuum. And we definitely can't think about fixing this in a vacuum for it to go back out into problematic society to revert to functioning as it previously did.
I definitely agree with both of you. And I think that that's just been a recurring problem in this nation, is that anytime you talk about health, the immediate thought is healthcare, and it's two different things. And even in the training that most medical students receive, they don't even get training in social determinants of health. They don't get training in health disparities. Most of the time, the training is only focused on there's a patient that's presenting these X, Y, and Z symptoms, and I'm going to treat it with this medication. And so half the time they're not even prescribing holistic approaches to addressing health problems. They're not telling you to work out. They're not telling you to eat healthy, because guess what? They're going to get a payment from the pharmaceutical companies for recommending certain prescriptions. And my very first job was actually working at an internal medicine clinic when I was 15 years old. And I saw this stuff firsthand, which is why I didn't even decide to continue with the healthcare path that I was on, because I was like, nobody is focusing on prevention. No one's focusing on addressing these different inequalities and inequities within education, housing, income, employment, all of these other things that are going to be related to health and are going to either promote health or cause barriers to people living healthy lifestyles. And so at the end of the day, unless we do take a wider view of health and really taking a more holistic approach to addressing health, we're going to still be in the same boat. And we can't just only focus on health insurance. That's only a small fraction of the problem. And even when you really look at health problems in and of themselves, only about 20% of the causes of health problems are linked to genetics or individual factors. A lot of it is like policy, environmental concerns, housing. It's just a whole host of things that are outside of just looking at genetics and someone having a predisposition to something. And so, yes, you could have a predisposition to diabetes, but if you have money, if you have a stable place to live, if you have food, if you know how to cook that food in a way that is healthy, if you know how to work out, like all of these other things can really change that narrative. And so we really have to take a more holistic approach to addressing health disparities and not just continue to focus on the healthcare system, because the healthcare system does not have all the answers. So it really does take that multi-sectoral approach to us addressing these problems.
Wow. Thank you, everyone. Thank you for letting me sit with you as we have this conversation. This was like deeply enriching.